now we are going to turn to hear more about Michigan. And I'm so pleased to welcome Dr. John Ianian. He's the inaugural director of the Institute for Healthcare Policy and Innovation at the University of Michigan, where he's also the Alice Hamilton Distinguished University Professor of Medicine and Healthcare Policy, Professor of Health Management and Policy, Professor of Public Policy, and a practicing general internist. So very, very capable person. We're so glad he's here. He and his team of 15 faculty members have completed an extensive evaluation of Michigan's efforts to expand Medicaid that began in 2014. And he's here to really share some takeaways of what they found. So thank you, Dr. Ianian, for joining us. I'll turn it over to you.
Thank you, Amy. It's a pleasure to be with you all. And I want to say at the outset, North Carolina holds a special place for me. I went to college at Duke, and my wife grew up in Wilmington. And in fact, we often get together with her extended family in Wilmington, where we'll be 2 weeks from today for our next family reunion. So I'm really pleased that you all are addressing these important issues of healthcare coverage and costs and quality within North Carolina. I have a few slides to share with you our experience from Michigan, and if we could turn to the next slide. So as Amy mentioned, I'm at the University of Michigan. I'm leading a team of faculty who've been evaluating our Medicaid expansion program, which is called the Healthy Michigan Plan, which was enacted by our legislature in the fall of 2013 and took effect in the spring of 2014, in that first year when states were eligible to expand Medicaid under the Affordable Care Act. The next slide. So this was the signing ceremony of the Healthy Michigan Plan. Our Governor Rick Snyder at the time, a Republican, signed the bill that was passed with bipartisan support from, at the time, a Republican-controlled legislature, but support from both Democratic and Republican legislators. And at the signing ceremony really captured that bipartisan nature. Congressman John Dingell standing beside the governor, Democratic congressman from southeastern Michigan, as well as legislative leaders from both parties and political and business leaders and health system leaders from across the state. And this was really developed while it was under the federal authorization for Medicaid expansion, it was designed as a Michigan program for Michigan residents. And so really when this program is discussed in Michigan, it's always referred to as the Healthy Michigan Plan and only occasionally as Medicaid expansion among both the enrollees as well as the broader residents of the state. Next slide, please. So I actually joined the University of Michigan back in 2013, right around the time when our legislature was debating this new policy. And one of the first articles I wrote as a faculty member at Michigan, leading our new Institute for Healthcare Policy and Innovation, was sort of how and why Michigan chose to expand Medicaid. And as I mentioned, it was with bipartisan support and under a Republican governor. And in order to get that bipartisan support, it required some special provisions and modifications to Medicaid that were authorized by CMS, the federal agency that oversees Medicare and Medicaid, under a Section 1115 waiver. There was a very strong emphasis on primary care, a desire among legislators to help people get better care for their chronic conditions and avoid the need to go to emergency departments with complications of those chronic conditions. And so really was built on a foundation of good primary care and managed care, which had been established for nearly a decade in our Medicaid program in Michigan prior to the expansion of Medicaid. And then what really, I think, created the bipartisan support for Medicaid expansion in Michigan was some of the market-oriented reforms that were included, such as cost sharing, both modest premiums as well as co-payments at the time of service, financial incentives for healthy behaviors, trying to connect people with primary care and work on things like preventive care, screening for cancer, smoking cessation, healthy diets, better physical activity. All those things are healthy behaviors that our Medicaid enrollees in the Healthy Michigan Plan can get reduced cost sharing as if they follow those healthy behaviors with the guidance from their primary care providers. And then the legislature also instituted My Health accounts, which are like health savings accounts in private insurance, where enrollees receive quarterly statements on both what's being spent on their health care as well as what their cost sharing obligations are. And they then pay those on a quarterly basis, not directly to their healthcare providers, but to a contractor that the state uses with the Medicaid program to collect those cost-sharing payments. And the goal was really better access to care for low-income adults, especially those with chronic conditions or preventable health problems, as well as the increased federal funding. So this program brings about $3.5 billion of federal funding to Michigan each year. And I'll talk a little bit more about that in a few minutes. But as I mentioned with the signing ceremony, one reason this was approved by our legislature is that not only did it have strong support from the healthcare community, the State Medical Society, the Nurses Association, the Hospital Association, but also support from our Michigan Chamber of Commerce and State Small Business Association that saw it as boosting the economy and strengthening the workforce in Michigan at the time this law was enacted. Next slide, please. So as I mentioned, we brought together a team of faculty. When you expand Medicaid under a Section 1115 waiver, it requires an independent evaluation. Because we're a public university, we have a standing agreement, a master agreement with our Department of Health and Human Services that enabled us to develop an evaluation plan that was approved by the state and the CMS, the federal agency overseeing the waiver. We brought together faculty from 5 different schools on campus, healthcare professionals, as well as economists and social work and faculty. And we were tasked to look at changes in insurance coverage, what happened to uncompensated care in hospitals, how new enrollees were using health services and their health outcomes, what was happening with their health behaviors, and then finally, the influence of some of these cost-sharing requirements on enrollees. Next slide, please. And about 1.5 years ago, we were actually recognized, the Washington Post was doing a news feature on the status of the Affordable Care Act, and they recognized our work as a hub for understanding the ACA's effects because we have been rigorously evaluating the Healthy Michigan Plan since 2014. Next slide. And first and foremost, what we and others have found is that the rate of uninsurance in our state went down statewide by about half, but in some of our urban and more rural areas, it went back down by as much as 2/3, like these data show from Detroit. And not only did coverage go up and uninsured rates go down, but for example, in this story on Vox.com, another news feature, really emphasized from the patient's perspective and the healthcare professional's perspective what was happening. So this was actually a story told in this article of a middle-aged woman who'd gone without insurance and without care for a period of time before she gained Medicaid coverage in the Healthy Michigan Plan, and how this was affecting her life in terms of better control of her chronic health conditions. Next slide. And so when we looked at that statewide, and we've been surveying several thousand enrollees each year over the past 5 to 6 years, what we found was before people gained enrollment in the Healthy Michigan Plan, only about 40% had seen a primary care provider in the year before they gained coverage. And about 1/3, 2 in 6, told us they'd gone without needed care during that prior year. Within the first year after enrollment, 85% of those we surveyed had seen a primary care provider, and the rate of going without needed care was down by about half. And we also heard from enrollees, 85, 90, 95% telling us they had better access, equal or better access to primary care and prescription medications. Next slide, please. And when we asked about their health, comparing before they gained the Healthy Michigan Plan and after, 40% told us their mental health or dental health had improved in the first year of coverage. About half told us their physical health had improved. And then thinking about employment outcomes, 55% of those who were working said they were able to do a better job at work because they had this coverage and their health conditions were cared for. And of those who had jobs, the 55% were better able to look for work, and 69% of those who had a job did a better job at work because of their coverage. Next slide, please. We've also tried to track racial and ethnic differences in health outcomes and employment. And this just shows some of our findings published last year, where we found that particularly for Black enrollees in the Healthy Michigan Plan, they had the largest gains in employment between 2016 and 2017, for example. So as you can see, of the enrollees that we're surveying, somewhere between 57% and 72% of enrollees are working and gaining employment over the time that they're covered. Next slide, please. I just want to, in closing, just mention a few personal stories of those who've gained coverage. So this was a man in his late 30s or 40s in the Detroit area talking about his physical health and ability to work. If you don't know what's causing your ailment, you're not able to get the medications you need or the care you need, that prevents you from being employable. And speaking back to the Montana experience that Hemi was referencing, he noted that he was able to start school to become a semi-truck driver, and he needs to know what's going on with me if I'm being careful for myself on the road as well as others. Next slide. A woman, a younger adult in northern Michigan, which is a much more rural part of the state, talked about her mental health and said, I've personally gotten better since being able to seek help for my mental issues, and that falls out over the rest of my life. I'm happier, I'm more able to work, I can function. And then lastly, in our Medicaid expansion on the next slide, we included dental coverage and found that that was a particularly important benefit for many of these new enrollees who had gone 5, 10, 15 years without dental care. And this was an example of another man in the Detroit area saying, my teeth were pretty bad, they fixed it up fine, and now I feel better when I'm looking for a job. I feel better because my appearance has changed a lot. That's helped me a lot physically and mentally. Next slide. So in the last section, I just want to talk about some of the economic effects, and then we can open it up for questions or comments. First, as we were tasked doing our evaluation, we looked at hospital uncompensated care costs and found that they were reduced by about half during a time period when there was no reduction in uncompensated care or charity care in hospitals in non-expansion states. And that's shown on this next graph, where Michigan is shown in the red line. And if you look prior to 2014, there was a fairly flat level of uncompensated care, about 3.5% to 4% in Michigan. And within just a couple of years, that rate of uncompensated care had gone down by a little over half. So that was down around 1.6% in 2017. And that's in contrast to the green line showing uncompensated care in average at hospitals in non-expansion states, which over this time period saw a gradual increase from 5.5% to over 7% of their hospital budgets being required for charity care or uncompensated care. And then on the next point, we found in the economics, we found that household economic outcomes improved for the low-income adults who gained coverage in Michigan. So here we linked credit agency data from TransUnion to Michigan Medicaid enrollment and compared it to a similar linkage for low-income adults in non-expansion states. And as shown on the next slide, we found reductions in unpaid bills and credit card loans, as well as medical bills being reduced by over $500 on average for these low-income adults. And importantly, fewer bills being sent to collection and fewer people becoming subject to home evictions and bankruptcies among those who gained Medicaid coverage in Michigan. And then a third economic outcome we found is that expansion actually improved the state's fiscal position. And that's because when we look at both the federal funding as well as the increased economic activity and the tax revenue, we found in Michigan, at least for the period from 2017 when we began covering that state match that's required, initially 5% and now 10%, that Medicaid expansion pays for itself. And on the next slide, when we modeled this with the economic forecasting team here at the University of Michigan that forecasts tax revenues for the state budget, what we found was that employment increased by about nearly 40,000 jobs in 2016. And even by 2021, still 30,000 job increase in employment. That increased employment generates about $2.3 billion in increased personal income annually. And that increased income leads to new state income and sales tax revenue at about $115 million a year, which is our state's share of the match for the Medicaid expansion. So at the next slide, and I think we're approaching the end, the take-home points that I leave you with is that At least we found in Michigan that coverage and access to care have improved substantially for the low-income adults who've gained coverage. Many enrollees report improved physical, mental, and dental health and better ability to work, particularly among those with chronic conditions like diabetes or high blood pressure or depression, where we know good medical care makes a difference. And then finally, financial outcomes have improved substantially for the individual enrollees, our hospitals in the state, and the costs of the program have been offset in the state budget based on the increased employment and economic activity in the state. So in closing, we have more information on our Institute's website, and I think we have an issue brief that we'll be able to share with all of you after today's presentation, and I welcome any questions or comments that you have.
Thank you, Dr. Aineen. That was, really impressive evaluation work, and I know that is not easy work to do. I see there's a question in the chat, but also Chip, you were just coming off mute. Do you want to go ahead and ask a question? Yeah, go ahead.
Thank you. Thank you, Dr. Aineen. That was a great presentation. I loved the fact that your study has really shown a full circle of the impact of what you've done in Michigan. As I was noticing the increase in primary care visits and the way that they're more controlled on their medications, one of the things that we've talked about extensively here is that we're probably going to see an increase in per member per month utilization if we were to expand. And then that would taper off over time because more people would be going to primary care doctor, getting their regular visits. Have you had a chance to look at that at all? Did you see a trend there?
We have, and as you might expect, for people who've gone without care, particularly if they have any known or newly diagnosed chronic conditions, there tends to be some pent-up demand for care, and there were strong incentives for people to get in to see a primary care physician within the first several months after gaining coverage. And so we did see a bump in the first year, and then once people get established with a primary care provider, either a private doctor's office or a community health center, that tends to stabilize, and it's offset by some reduction in emergency department use. So before Medicaid, people enrolled in the Healthy Michigan Plan, about 15 to 20% told us that they use the emergency department as their main source of care. And that went down to about 1% when we went back and asked people 1 to 2 years after they gained coverage. So, people still sometimes need emergency departments, but we're finding they use it for more appropriate, emergent conditions, and not because, they haven't had access to medications for their diabetes, for example.
Great, thank you. And I know Representative Cunningham, I think, had a question. You want to go ahead and ask your question? Yeah.
Thank you, Dr. John. I don't want to mess up your last name, but Dr. John, a couple of questions on the cost sharing. Do we know what that average is for the enrollee that's participating in the program?
Yeah, so the premiums are levied for those at 100% of poverty or higher, which is about, for an individual adult, about $13,000 a year, and it's 2% of their income. So that that's what the premium is, and then for the co-payments that are required for doctor's visits or medications, they're very low, on the order of $1 to $8. Although for non-urgent use of the hospital and the emergency department, they can be higher, in the range of $50 to $100.
Okay, my last question is sort of connected. On the growth of people becoming employed in the jobs that were created, do we know what the average salary was, and also the minimum wage in the state of Michigan?
Those are both good questions, and maybe I could get back to you through the Duke team about that. I don't have those numbers at my fingertips.
We're happy to follow up on that. Yes, thank you. I think Representative Adcock was next, so go ahead.
Yes, thank you so much. Terrific presentation, and very impressive that you began measuring results from the very beginning. I think that's great. And so my question is about that evidence and whether you evaluated the impact of the Healthy Michigan Plan on the state's number of hospital closures and the hospital's bottom line. I think your graph probably showed that pretty well. And then you just discussed the ER utilization. So I would like to know the impact on hospital closures, because I know many of our hospitals like other states that haven't expanded Medicaid have a higher rate of hospital closures than those who have expanded. So thank you.
Sure. So, to my knowledge, we've had no hospital closures. I want to be sure that's accurate, and I can double check that for you. But I'm not aware. And at a time when I know in some other states, like I've advised legislators and health leaders in Kansas, they've had a big issue with closure, particularly of smaller rural hospitals. And that's been an issue of concern. With the lack of Medicaid expansion.
So follow up, please. What was your experience like pre-Healthy Michigan plan? Had you not had a lot of hospital closures pre or post, or is that information you'd have to get to us?
Yeah, that's a good follow-up question. And let me check into that, because I joined Michigan, the University of Michigan, right around the time when we were expanding Medicaid. So, now I'm a practicing physician in Michigan, but before that I was in Boston. And so I can check what the trends were during that 10-year period or so before we expanded Medicaid.
Thanks. Intuitively, you would have to believe there would be a positive impact on closures, but of course, since y'all are so good with getting quantitative data, we'd love to know. Thanks.
Yep.
I think Tommy Newton had a question about if you want to say that, or I can read it for you. Would you like to chime in, Tommy? Okay, I'm going to read it. Was there an increase in percentage of primary care providers who participated in Medicaid as a result of this program?
Another excellent question, and one that our governor in particular was particularly concerned about at the time when he was deciding whether to support Medicaid expansion back in 2013. Because one of the concerns was, if we added several 100,000 people to the healthcare system with new insurance coverage, did we have capacity to accommodate them? And some of my colleagues actually at the University of Michigan led statewide surveys of primary care providers, both before we expanded, that suggested that yes, providers were willing and had capacity to take on the new patients. And then importantly, we followed up after, both 1 and 2 years after Medicaid was expanded, and actually with what we call secret shopper studies, where we have students at the university acting as patients, calling primary care offices around the state to see if they're taking new patients, and saying that they're in one of the 3 main categories of insurance: Medicare, Medicaid, or private insurance. And what we found was that a little over half of providers in the state were taking new Medicaid patients before the expansion, and that actually went up a little bit to a little over 60%. And the number taking new patients with private insurance was stable around 80 to 85%. And importantly, we also found that wait times for new appointments stayed about the same, about 1 to 2 weeks for a new patient appointment, regardless of the type of insurance, if a practice was taking new patients. And then what we found in our second follow-up was one of the ways that many of the medical groups and community health centers handle that new capacity was by greater use of physicians' assistants and nurse practitioners, and particularly in community health centers, but also in private medical offices. That was a way to get patients in and expand capacity in what they viewed as a cost-effective manner.
Great. Another question for you. These are great questions. Thank you all for chiming in here. Did Michigan pass any other legislative or make regulatory reforms that facilitated the care of this increase in covered individuals?
That's my question, Representative.
Okay.
Here. And so you did a great job, John, of alluding to this, but my question is, you talked about capacity, provider capacity, and the surveys and everything that you did. My question was about whether, in addition to those, seeing what you already had in place, if there were regulatory reforms made or legislation passed that would remove any barriers to the providers that you needed all over your state in order to meet the demand of these, more people with healthcare insurance. Do you happen to know that offhand?
Well, I think it was the regulatory component would come through our contracting that the state Medicaid agency does with managed care plans around the state. And, I would say, throughout the state, we've got strong participation from managed care plans. So they really built on that pre-existing collaboration and built-in incentives, for example, for the managed care plans. If they could demonstrate that people were getting connected to primary care within the first several months after getting coverage, then there were financial incentives built in for the managed care plans. So that's one example of a regulatory change that was part of the legislation, but then implemented by our state Medicaid agency in the contracting process.
Great. Tunde, you've been patiently waiting. Go ahead and ask your question.
That's fine. Hey, John, good to see you, and great presentation. Just a quick question. Did you observe any impact on the overall healthcare affordability in the state of Michigan once, Medicaid expansion was up and running? So, I mean, like you pointed out, one would expect, right? Improved access, people in the system of care, reduced ER visits, unnecessary hospitalizations and so on. But then there's the other side of the equation, which you kind of mentioned around uncompensated care, right? And one would expect that the confluence of access, system of care, reducing uncompensated care should bring down overall pricing and costs of healthcare. Have you experienced that at all?
Yeah, well, we've tried hard to understand that. One of the challenges is that, particularly for commercial or private insurance, a lot of the spending and pricing is determined through contracts between insurers and providers, and we've done some qualitative work, interviewing leaders on both sides of those negotiations that suggests it did help to slow the growth of healthcare expenses and premiums for those with private or commercial insurance in the state. But it's very difficult to get good quantitative data to back that up because it's all sort of I think considered fairly confidential information in those contracts. So we found some suggestive support for that, but it's hard to make a convincing case. And also I would say we also in that process we learned that there are so many other factors in addition to uncompensated care that govern those spending and pricing decisions that even with a major change like the Healthy Michigan Plan and Medicaid expansion, that uncompensated care is still outweighed by many other factors like high deductible health plans or rising prescription drug prices, that may be contributing to spending growth.
Yeah, no, absolutely. I was hoping you'd that's $1 million question, no pun intended.
Yeah.
That's helpful. Thank you.
Great. Senator Robinson, did you have a question? I can read it or you can just chime in here.
Well, certainly just one, and thank you for the presentation. It's really been extremely helpful. It's interesting to hear about the voluntary workforce. I think that that gives us some insights into some of the workable solutions that people do want to work if they're able to, if they have the support to do it. And so I think that helps to dispel some of the myths. But I was wondering on the provider side, did you increase the reimbursement rate for providers? I know probably with the managed care, you had already probably had some increase, but was there an increase since you did not lose providers, you brought others in, or you were able to serve the people there?
Yeah, to my knowledge, we didn't have any extra increase in provider reimbursement, beyond what would have been negotiated. Our state Medicaid agency every 5 years renegotiates the contracts with the Medicaid managed care plans. So I think the short answer is no. There were some of those financial incentives I mentioned about the managed care plans could earn bonus payments, and I think some of the plans then offer those bonus payments to their participating physicians, if they did a good job getting patients in both to have a primary care visit as well as complete their health risk assessment and their health behavior plan. So that would be the main way. There were some financial incentives built in.
Great.
Okay,
And
thank
I
you.
think- Fantastic. And I maybe we have time for maybe 2 more questions. I have one, and there was one in the chat. So anyone else want to ask their question before I go to the last 2? It's been a good discussion. Okay, I had one question for you, Dr. Ayanian. So with respect to people transitioning to other forms of coverage, have you seen what has happened, for those who are eligible for Medicaid expansion in Michigan? Are they linked to, other services, other jobs, and they transition to other types of insurance? And is there anything you can comment on that with respect to your experience?
Yes, Amy, I went back and looked at, in addition to the issue, the brief that's in the chat box here, we have more detailed reports on our website for people interested in more depth of what I've discussed. Regarding we have on 3 occasions gone back and surveyed people who left the program, and one of the key things we're interested in is, are they working, are they insured? And across those follow-up surveys, basically what we find is after leaving the program, on average, about 35 to 40% of people have employer-sponsored insurance, which implies they're employed. About 35 to 40% are uninsured. They may still be working, but it may be in a job that doesn't offer insurance. And then the remaining 25 or so percent is pretty evenly divided between individuals getting individual coverage, which we would presume is mainly through the marketplace, and then another half, 10 to 15%, going on to some other form of government assistance like Medicare or the Veterans Administration coverage. So, the age range for this program is 19 to 64. So every year, a subset is aging into Medicare at age 65. And then some people qualify for Medicare because of disability or end-stage kidney disease.
Okay, great. That's really helpful. Thank you. And then there was one last question from, I think, Representative Cunningham. I don't know if you want to ask that or if you want me to go ahead and read it in the chat. I can read it. Okay. So is there data being collected on chronic health issues and improvement in healthy outcomes that cost less in the long run for Medicaid state dollars?
We have a fair amount of data now showing that people with chronic health conditions are better connected to care. They're taking, and these would be conditions such as asthma, diabetes, high blood pressure, depression, chronic heart disease. They are taking their medications more consistently. They're reporting better health status. It's difficult to, I think all of these things we know from other research are cost effective, meaning it's good value to get somebody with heart disease on cholesterol medication, or somebody with high blood pressure is probably one of the best things we do for people in primary care and chronic diseases, getting their blood pressure under control and preventing strokes and heart attacks. We don't have a long enough time window yet to say whether it's cost saving. In terms of the health benefits, it's clearly cost effective relative to other things we do in the healthcare system. It's very good value, but it's an open question. And obviously, if we're helping people live longer and better lives, over time, they'll use more healthcare services. But what we value is the length and quality of life that they have, and are we spending effectively to help them achieve that?
Great. Thank you. Okay, well, what a fantastic presentation and set of questions. Thank you so much, Dr. Ayanian, for joining us, and thank all of you for your.
Yeah. Be happy to answer any follow-up questions that come up. I know we had a few from earlier in the conversation, but if any others come up in the discussion after this, please let me know.
Okay, yeah, and if anyone else has other questions, feel free to route them through the Duke team. We have a running list of things we're going to follow up with Dr. Ayanian on, and then we'll circle back with all of you. So we can also put you in touch on his information here. So we're always happy to connect you as well. Okay.